Good morning, everybody. I think I thank Dr. Prasad and
So
the
before
entire
Simon, I will just request audience to really listen to this because I'm going to ask you a question after this.
I hope you don't ask me the questions. I think we are hip surgeons. We concentrate only on hips. We get hips arthritic, dysplastic, dislocated, and we want to do something like this. And our entire concentration is on basically getting the version, getting the implant position right. And usually we are fine. Sometimes when we are faced with situations like these, then we are actually forced to look around the hip. See, I'm talking about unstable hips in which the apparent local pathology is all fine. You can't find a problem. You have to start looking around. And this is where spinopelvic alignment comes in position. This is how we check the stability on table. We're all doing this. Posterior approach, anterior approach. We actually keep moving the patient's hip through range of movement, and once we're stable, only we leave the table. That's what we all agree on. But in spite of that, 32% of recurrent dislocators now come in a position which is actually the cups are in good position, still they dislocate. So spinopelvic relationship is important and we need to take. Why this comes is that when you put a cup, you are looking at your local landmarks. You're looking at the TAL, you're looking at the posterior wall. As Dr. Mrinal said, I'll leave a little bit of, the superior cup exposed and the inclination is fine. The position of the cup is wonderful. But what is the position of the cup in respect to the person or the pelvis or the spine in totality? This is what we had to also see. And dislocations of THR, so nicely done or an average done or a good THR, it dislocates during postural changes mainly. Standing up, sitting down, picking an object from the floor. And these all must be considered when you actually look at the post-operative results after THR. So let's see what spinopelvic alignment hip what actually is. So when you're standing and when you start to sit, the hip does not flex to 90 degrees. This is what you have to understand. It is a pelvis which tilts posteriorly. The lumbar lordosis which is there in standing, it actually reduces. So what it does is that the inclination of the cup, which was in the position in which the cup was inclined, the acetabulum was inclined in standing, it changes. And you are doing a cup in a virtual standing position because the patient is in lateral, the hip is extended. And once this patient starts to sit down, the anteversion of the cup that you've placed on table, which you feel is wonderful, will change. The inclination will change. The anteversion inclination will both increase. And at that time, if there is a problem, the cups may dislocate. Who are those patients? Actually, this is not to be seen or not to be anticipated in each and every patient. It's not that big a problem. But certain patients in whom you have degenerative spine, previous spinal surgeries, ankylosing spondylitis in which the spinal biomechanics is deranged, you should have a threshold to see for these patients for this kind of a problem. What do you and how do? You get a simple X-ray spine, pelvis and proximal femur standing. So one X-ray in which everything is there. And people who are actually looking into it in more detail can also have a CT for an acetabular anteversion, but you need to have a great radiologist to give all these angles to you. So a spinopelvic alignment, the sagittal balance is by hip factors and the spine factors. The hip factors are by pelvic tilt, pelvic incidence and sacral slope. I'll come into it. And the spine factors, obviously the angle of lordosis and kyphosis has to be taken into consideration. What is a pelvic tilt? It is an angle between the vertical line going through the center of the head and a line joining the middle of the S1 end plate to the center of the head. I don't think you need to remember these values. You just remember there's an angle called a pelvic tilt. The pelvic incidence, the angle between a line perpendicular to the end plane of S1 and a line connecting this point to the head. So the pelvic tilt, pelvic incidence, and now the sacral slope, as the name itself mentioned. This is the angle between the superior end plate of the midpoint of the superior end plate of the S1 and the angle and the horizontal. This is the angle that you have to consider. The normal is around 42 degrees plus minus 8.5. Again, the values are not important. You have to see how this changes in your normal, in your patient in whom you're going to undergo a total hip replacement. Of course, angle of kyphosis and lordosis will change in patients who have been fixed. So, At the risk of being oversimplistic, this is a very complicated topic. I've actually tried to simplify it so that we get a grasp, a bird's eye view of what we're looking at. We can have a hypermobility situation and we can have a stiff situation. A hypermobile is one in which 30 degrees or 30 degrees or more movement of the pelvis occurs when you're going from an upright position to a sitting position, and a stiff situation in which the pelvic does not move that much. That means 10 degrees of less of movement of the pelvis occurs. The classification is very simple: flexible balanced, flexible unbalanced, rigid balanced, and a rigid unbalanced. Flexible and balanced. Ladies, we have not been able to understand ladies in our lives, and the hips also, it's true. Some of the females actually have this kind of a behavior. But fortunately, in spite of having a flexible, a very hypermobile pelvis, these hips for some reason don't dislocate. So don't worry about them. Then you have got a flexible and unbalanced. In this, what happens is that because of maybe a high BMI, the belly is protuberant, or thigh is very thick. So the flexion of the hip in these cases is less than 50 degrees once you come into a sitting. So what happens is that when you to sit, the pelvis moves further back, and the movement is more than 30 degrees. The pelvis has to move more than 30 degrees to accommodate sitting. This can also happen in some neurological disorders like Parkinsonism. So now what is the implication of it? When you're sitting, the pelvic tilt will increase. The acetabular anteversion, which you on table have felt wonderful, will actually increase. And once these patients sit, once the anteversion increases what you have put, and you think the hip is stable, what happens is that there's a chance of a posterior impingement and the hip will dislocate anteriorly. So you have to keep that in mind, and on table, in spite of using a posterior approach, keep your hip less than anteverted. But then these are all subjective, and this is where technology may chip in. With the robot in now position, you can actually get a lot of inclination. The keep less anteverted would be more objective when you use a robotic technology. Then again, we have to come to a rigid and balanced. That means the pelvis moves less than 10 degrees due to stiff spine, which has already been there due to degeneration and previous lumbar fusion. What is the implication? The pelvis here will not tilt. So the acetabular anteversion will not increase. So once these patients tilt, there's a chance of an anterior impingement and a posterior dislocation. So you have to keep these cups more anteverted than what you would usually do, because there is a chance of an increased posterior dislocation. So now there's a rigid and unbalanced. In this, the pelvis moves to less than 10 degrees. Why? Because the spine has been fixed, or the spine has been fixed by the surgeon itself, or basically the spine is stiff in a position of less anteversion. So this native acetabulum is already in a higher anteversion compared to what you will get. So this pelvis does not have any more chance or scope of tilting. So this happens in a severe spine stiffness, long segment lumbar fusion, and kyphotic fat plaques. And what is the implication is that as the increased acetabulum is already there, posterior impingement and anti-dislocation can occur in these patients. So in these are those patients, you can actually send these patients. Whenever you have a doubt in these, you should actually discuss with a spinal surgeon, and you can send these patients for a spine surgery first and keep the cup less anteverted in spite of having a spine surgery done first. Now the easiest solution to a simple orthopedic surgeon like me is, what I want is maybe use a dual mobility in all the cases. But then this is controversial mainly because dual mobility means more interfaces. The dual mobility also means we are looking at a technology which is new in market, and we don't know where survival is going to be, as good as it is. But then there is no talk without a controversy. And this is the 14th session of this arthroplastic conference. I hope to see you guys sometimes next year and where we can actually discuss this further. The take-home message is, beware of THR in patients with spinal problems. You should identify your problem patients first. That is the biggest thing. A lot of us are very happy with our local landmarks, and we don't see the patient in totality. This is what we have to do, even in your primaries. To sum it up, a hypermobile, unbalanced, you decrease your version on table. A rigid balance, you increase your version. Rigid, unbalanced, decrease version, consider spine surgeries first. And when in doubt, a dual mobility is handy. Thank you for your patient hearing. And I think Dr. Rajput does not ask me any questions.
No, it's for the audience. So if you have increased lordosis, What should we do with the cup? Anybody who's been listening? So if you have more lordosis, what should we do with the cup? So you need to antivert more. You have a rigid back, flat. What do we do with the cup? Okay. So now I'll ask you the question. How much can you do this? We said less antiversion, more antiversion. How much are you allowed? Can you put a figure to that?
There is a correlation for how many degrees.
Yeah, no. So, no, I'm saying the maximum. So you can't go more than 10 degrees. Okay? If you have to somehow reason that you need to go more, do some more on the femur, but not on the acetabulum. Okay, suppose you need 15 degrees. So only till 10 on the acetabulum, go a little bit more on the femur side. So in that case, you can't put uncemented implants. You might need to go for a cemented one. So this parameter is very important. The trouble is, I've had about a month ago, 12 years ago I did a THR, and now he's come with a dislocation. Because 2 years ago he had a spine surgery. So it's like something we used to think, oh, doesn't happen in our country, it happens in US. It's beginning to happen here also. Because our spine surgeons have got very, very active. So it does happen. Any more questions for Simon?
I need to add something. I think this problem occurs in only 1 to 2% of the total hips we are doing. So it's now because we are trying to, maybe where the threadbare discussion is being done and everything in hip arthroplasty or knee is being like from alignment to everything. That's why this has come up, this new concept. But we had those 1 or 2% dislocations earlier also when we did not know this concept. In those stiff hips, fused hips, we did have problems, Now, the problem is that if you don't have navigation, if you don't have robotics, how do you know how much compensation you're giving on table? You can't quantify that. If I use these parameters and calculate, okay, with the robot I can do that, the 7 degrees of antiversion needs to be increased. I cannot do that with my, eyes. So you need technology in such difficult cases to help you out, where you can actually, with the robotic systems like Mako and all, they have, this inbuilt software where you can add on that 7 degrees or 10 degrees of antiversion and you can just, get away with this problem. But once you're doing it with your bare eyes, it's very difficult how much you're increasing. You might do it the other way around and it might start dislocating anteriorly. So that needs to be taken care of.
So just I'll put one more thing into perspective. We are only talking about dislocation here, but there is another thing called impingement. And the more you do robotics, you realize a lot of this planning which you had done pre-op on table, you'll see this green marks coming in, which means you are red dots, which means you are impinging. So that's very common now. So what we never knew this before. So I think impingement and pain, little bit around without actually frank dislocations is actually quite common. So we can avoid that if you look into this a bit more deeper. So it's not just dislocation, impingement. Yeah, Sudeep, you want to say something?
Yeah, you're right, okay, that you need a robotic to actually control exactly, but you have to realize that everything is done in a position which patient is not mobile, relaxed, okay. So you should have a parameter. So you need to at least look into the spine X-ray to start looking, okay. We have not gone that everybody's or 50% of the surgeons are using robotic. It's I think 10% or less than that arthroplasty surgeons are using robotic. Maybe 2%. So at least to those who are doing normal, non-robotic, at least they start looking at the spine before the surgery in standing and sitting, which will not be difficult. So that is the one message that we should give. Absolutely. And the second is that those flexible and unbalanced spine, they don't dislocate while standing to sitting, they dislocate anteriorly when sitting to standing. So that is another thing that we need to look. When the patient stands, it starts walking and then dislocates anteriorly, not when the patient is sitting. Is that the patient when stands, it dislocates.
So I think last question. I think
that's a very valid point you said. Everybody cannot have a robo, but we can actually have our mind that this patient may. We need to find out that challenging patient.
Sir, as I saw in your video, you were flexing the hip to 90 or more than 90. So don't you think that mimics the sitting position as we are putting the patient in lateral supine lateral position, so that mimics a standing position? But once we flex the hips, so that comes to a point like it is a virtual sitting position.
I think this is exactly what I said in the next slide. When you sit, the hip is not flexing to 90 degrees normally. The pelvis is tilting back. This is what we never understood sometimes earlier.
Okay.
So your acetabulum is maybe perfectly placed with your position to your tail and everything. But when you're sitting, your pelvis is actually moving back. It is not the hip which is flexing to 90 degree. We always thought that the hip was flexing to 90 and the pelvis remains stable. It's not head. The actually pelvis is moving. That's what I said in the next slide.
So is there any intraoperative trick to check that?
That is a great question. That is what we are saying. We still are learning.
That's why you need technology.
So I think we'll move on with Dr. Rajkumar. Some wonderful cases to be seen. So please pay attention.
Yeah. So this topic, in continuation with what Mrinal showed about the proximal femur fixation. So this proximal femur fractures we will be encountering in our day-to-day practice very commonly, and because of our geriatric population, life expectancy is growing up, so more and more trochanteric proximal femur fractures. To make it very clear and simple, proximal femur fractures, it is like two parts. One is the neck of femur and one is the trochanteric fracture. So we have to differentiate and we have to make sure what fracture we are dealing with. So these are, it can be named as trochanteric or neck of femur fractures, whatever it is, these are all proximal femur fractures, and either it is trochanteric or femur fracture, but it is all unstable. That is the most important thing we have to diagnose, that these are all unstable fractures. And these unstable fractures, the first choice of treatment is internal fixation. No doubt about it, it has to be fixed internally, and based on that fixation we have to see how we are going to mobilize. So I'll take you through some examples, case examples here. 73-year-old man, RTA, the surgeon did DHS fixation. But if you look at this X-ray, preoperative X-ray, it is an unstable fracture. Trochanteric fracture, unstable. The DHS fixation was done, and this is how it failed. In 3 months' time it failed, and in spite of that, the same surgeon, he has removed the DHS and did a bipolar process. Again, what is the problem here? It is not the right choice of implant. So after that, this has happened. So ultimately, it ended up in a total hip replacement. But the key point here, the first identification that it is an unstable trochanteric fracture, where a bipolar DHS also is not good and a bipolar is also not good. The next example, 80-year-old female, hip injury. Again, the proximal femur fracture. What is that? It is an unstable fracture. Unstable trochanteric fracture, 80 years. What we have to give the patient one single surgery. But what was done? It's a surgeon has done a bipolar processes, and this bipolar processes in an unstable trochanteric fracture. What has led to? This is what has happened, dislocation. So why this dislocation? The wrong procedure. What is that? In an unstable trochanteric fracture and a bipolar has been used, offset problem, instability. All this has caused the dislocation. So hemiarthroplasty is never a solution for an unstable hip fractures. Keep that in mind. Again, 69-year-old female patient, the surgeon has used a unipolar bipolar processes. What has happened? It has gone in for a revision THR. 3 years post-op after revision THR. 70-year-old male, again a bipolar process. Why a 70-year-old male in a proximal femur fracture, a bipolar process has to be used if the patient is physiologically active. So this has happened, broken stem, then now we have used a revision stem. So the key point here is identification of the fracture, whether it is stable or unstable, what exactly needs for that patient is the message. Most important thing. So the message here is hemiarthroplasty is not the procedure of choice in unstable proximal femur fractures, particularly in elderly. So if you look at the literature, unstable femur fractures, 20% of mortality in the first post-operative period. So these are all unstable fractures. It goes on in for failures even if the fixation is done, particularly if not the right fixation is done, then it goes for failure. Failures are very high in unstable fractures. So we have to make sure we have to understand why these failures are happening, because of old age, severe osteoporosis, instability, unstable fractures, and the comminution. All these contributes to the failures. What is the other option then? THR. What is that in an acute fracture? Why THR? It is not actually a THR. See, look at this unstable 75-year-old female, trivial fall, osteoporosis. You can do fixation, chance of failure is high. Whether you can do a bipolar, but again chances of failure. But the another good option is you can make sure you are not disturbing the abductors too much. You can use a distal loading, short distal loading titanium stem, and you wire all the trochanteric comminutions in the greater trochanter. I use a modular bipolar head. So this is what the question somebody asked now just some time back. Acute trochanteric fractures, elderly patients, short titanium, thicker stem. Don't use a longer stem, short titanium, thicker stem, and use a modular bipolar. You don't need to prepare the acetabulum because the morbidity is so high. You cannot do a 3 hours procedure in acute fractures. So this is a good option. So like a titanium stem, distal loading, and a modular bipolar is a very good option in an trochanteric fractures, unstable fractures. Again, one more example. Look at the fracture, very osteoporotic in the trochanteric region, unstable, almost 4-part fracture. So again, distal loading stem with a modular bipolar. Even in the literature, you can say the advantages are very less surgical time, offset is achieved, early mobilization, reduces morbidity and morbility, and we don't need to immobilize the patient for a long time. So the idea here is in the literature also they have reported that these stems serve very well, and particularly in acute trochanteric fractures. Bipolar modular bipolar in a uncemented distal loading stem gives excellent result, particularly in elderly patients. So now this is already trochanteric fractures, unstable, acute. We've seen what can be done. Now what happens when the fixation fails? I'll again take you through some quick examples. 51-year-old male, post-traumatic arthritis, DHS fixation done. Here definitely the patient needs THR. Just 2 principles we need to look at it. Implant removal and a THR. What is the stem we have to use? We have to use a distal loading stem which crosses the distalmost screw hole and an uncemented cup. So that should be the choice. No other debate here. This is the ideal stem. In this case, multiple implants are there inside. It needs a THR, no doubt about it. What is the plan in the preoperative plan? You will need all types of sizes of screwdrivers. So that is the preparation you have to, so that this fixation would have been done by somebody else. So you need all sorts of screwdrivers, and then you have to remove the implant and then do a THR. And you don't need to remove the wires. Only the implant has to be removed. Again, a distal loading stem and an uncemented. So post-traumatic situation, one case example was shown previously. We have to, again, what is that? We need to properly plan preoperatively. Post-traumatic arthritis, DHS is there, proper x-rays. What is that? Whenever we are planning a distal loading stem, take a good full-length x-rays, AP and true lateral. See the amount of bowing. In this a straight stem, a fracture can happen. So you have to be prepared for that. So preoperative planning is very, very important. So this is how it was used, a distal loading uncemented stem, titanium stem. Again, one more example, 81-year-old male, implant failure, like what Dr. Mrinal showed. Again, removal at distal loading stem. The key point here is, don't try to use a longer stem unnecessarily. You will get a false fixation. So you have to use a thicker, short stem, distal loading stem. That should be the choice of implant. Again, one more example. The key again here is cross the distalmost screw. That is the 2 years follow-up. Sometimes we again discussed about this infection. So this is a case where 3 years back a patient underwent a distal fixation. So multiple open fractures, multiple fixations. Again, you can see that blood initiation shows very high CRP, ESR. So the best is to remove the implant, do all the thorough debridement, put in a cement spacer, take the culture, treat appropriately, and then go ahead and do a second stage procedure, distal loading stem. Titanium distal loading stem and uncemented cup. Again, 56-year-old male, trivial fall, alcoholic, IT fracture. So a trauma surgeon can discuss what is the ideal situation, but in the end it has to be whether it is an unstable or a stable fracture. Select the correct internal fixation. Here 5 months post-op, 6 months post-op, patient is having pain, but the surgeon was waiting for the fracture to knit. That is again the wrong thing. Address it appropriately in the right time. What next? Again, 8 months post-op, patient is not able to walk. Still the surgeon was waiting, and finally the local surgeon, he has removed the implant and made the patient start walking, but still the fracture did not unite. So this is how the patient came to me. Lot of combination, unstable patient, head is already deformed, not much of bone left there. So ultimately the patient needed a distal loading stem and total hip replacement. But the key point here is again uncemented distal loading stem and uncemented cup. But the key point here is when to intervene. So in a proximal femur fracture, whenever it goes for failure, try to intervene at the early. Don't wait for more complex situations arise. So the most important thing is a distal loading uncemented stem. Whether dual mobility is needed, not always a dual mobility is needed. Assess the abductors. Most of the time you will be able to get away with the regular uncemented distal loading stem. One more quick example, 3 months post fixation, DHS, unstable trochanteric fracture, again a DHS, wrong implant. It should have been an interlock distal PF and nail, but still the surgeon has used a DHS fixation. Patient complaining of pain. The surgeon, what he has done, again he has underwent, the surgeon revised it with a DHS and a bone grafting. Again the wrong choice. So re-DHS fixation and bone grafting again failed. 2 months after re-DHS fixation. Came to us, the lab parameters, aspiration, and again single stage implant removal and THR was done. But perioperatively the culture was sent and unsuspected PJ. This has happened, so it was treated with antibiotics. So you have to be very careful whenever you are dealing with repeated surgeries. Even when you are doing a THR, take some samples, send it for culture. You can see unsuspected PGI, very much reported in the literature. You have to give at least post-operative 1 month of antibiotic. The last again, failed internal fixation. You can see that the most important thing here is the fixation is failed, arthritis is there. Whenever you see these kind of erosion there, you have to be very careful in dislocating when you are doing a THR. You have to dislocate and then try to remove the implant. If you don't do that, distal femur fractures can happen. So the key message here is you dislocate the hip and then you remove the implants and then do a THR. So that is how it was, even the distal fixation was fixed. So to summarize, all proximal femur fractures, either it will be pathological, unstable trochanteric fractures with arthritis, for non-union and failed internal fixation. So THR is the ideal solution, these kind of situation. And always remember, when you are dealing with this kind of complex situations, the go-to stem should be an uncemented distal loading titanium stem. No more cobalt chrome stems. Thank you.
So any question for Rajkumar? Otherwise we'll close this. Rajkumar, just a minute. Any question? So Rajkumar, there's some cases you showed where the first fixation has failed. So my question is, a lot of trauma surgeons, if the head is viable, they would still go ahead and actually fix this fracture, whereas an arthroplasty surgeon at this stage will change. So what is the message for an audience who does both?
See, it depends upon the patient's activity level, how many surgeries already underwent, and then we miss about that how much of loose screw, whatever is there, has eroded the neck and the head. So some trauma surgeons who are really very experienced, they might say bone grafting, do a valgus osteotomy, then fix it. But again the question comes, what happens if it goes for non-union? So that is where you have to discuss with the patient, assess physiologically how active it is, and then if your one surgery will solve the problem, I think the newer implants like the titanium uncemented stems and an hemispherical cup gives a good option. And the survival rate is very high. Patient can get back to his normal activities as quick as possible. If you do an osteotomy, bone grafting, again adds morbidity to the patient. So you have to judge based on all those things.
So I think the message we want to send to the audience is, get your first trauma surgery right. These are older patients, won't give you too much of chance. So get it right. So let's say if you have trochanteric fractures, fix them well, wire it, even put a plate across if you want. If it fails, then you need to be extremely good trauma surgeon to be able to refix it back. Otherwise, opt for arthroplasty, which is safer, easier in an average surgeon's hand. But use good implants.
Sir, how the titanium stems are better than chromium cobalt?
No, it's stronger. The elasticity of modulate. The cobalt chrome stems are rigid, strong. The chances of breakage. I have not seen a single titanium stem breaking, particularly like Wagner stem. So, and also the thigh pain. in cobalt chrome stems are very, very high, whereas in titanium stems it is not there. So, and also the bone regeneration in a titanium stem is very good, particularly in a cobalt chrome stems. When you don't have a proximal bone covering the stem, the chances of breakage is very high. So I feel, it is very much proven that titanium stems are superior. In fact, companies are withdrawing the cobalt chrome stems.
Can I add to that, Rajkumar? So the question which you, sorry, sir, you are gentleman, your question. So you asked about cobalt chrome stem. So this stem which you just saw, many of the cases, is actually a modification of a previous stem called AML. So the AML, when it was short, used to be the normal THR stem. We saw a lot of stress shielding happening proximally. The bone loss was happening because of stress shielding. So then they realized that the longer version is very good for revision stems. But that stress shielding still happens and you actually start bone disappearing. Whereas with the titanium stems, you actually see bone formation. So that's very, very important. Number two, the incidence of periprosthetic fractures while putting in the stem are so high with the cobalt chrome that you invariably need to keep your plate intact. So if you do many, you will realize that you've actually fractured distal to the insertion tip. So that incidence is also very low in titanium stems. So I think overall, that's why we moved away from cobalt chrome stems. The actual stem diameter geometry way of putting is very good. I have actually told Dipui, just convert it into titanium, you will have a winner, even better than probably Wagner. But they don't seem to be listening at the present.
So how you remove the distal part of the bipolar without getting the trochanteric osteotomy? I have seen 2 or 3 cases where the bipolar is broken and the distal part you have not done the osteotomy and then removed it.
Again, that itself is a big topic, how to remove, but quick point on that, it has to be assessed 2 things, whether that bipolar broken is cemented or uncemented. If it is a cemented broken bipolar somewhere, don't hesitate, ETO is the choice. Then if it is an uncemented broken, first is endofemoral, try to pull it out. The proximal will come out. Distally you have that long grabbers. I have a separate talk on that. You have a long grabber with the C-arm, try once or twice. If it is coming, pull it out. If it is not coming, don't waste time, straight away ETO. There is another technique. Sometimes what you can do is small window, just distal to it, but you have to plan where you are going to get your distal fixation. Based on that plan, make a small window, put a small Steinman pin or a curved pin, tap, 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 then it will come, pull a grabber. So on perioperatively, twice or thrice try, otherwise straight away ETO.
So in these cases also keep knee free. You can even hammer it down from the bottom. Okay,
Sir,
so keep your knee free for these cases.
Sir,
so I think we close this.
Sir,
Yes, Ajit,
Yeah.
you've been very quiet.
Yeah. What's your experience of this secondary protrusio after you use that bipolar in that osteoporotic fractures?
Protrusio?
Yeah, secondary protrusio. If you use bipolar in this osteoporotic trochanteric fractures, many of them come later on, 2 years, 3 years. Short term may be good, but why not THR? 10 minutes more job.
Yeah, if it is gone protrusio, you are asking?
You advised bipolar.
Bipolar what?
In osteoporotic trochanteric fracture.
The incidence of protrusio in these modular bipolars are not that much like a unipolar processes where the protrusio is so much, and all the modular bipolars in our local market, immediately they become a unipolar in a short duration of time, whereas these modular bipolar exclusively for these kind of situations they work well. So the incidence of protrusio is very low.
So I think I'll answer that, also add to that. If you have a fresh fracture, trochanteric, where you are putting implant, bipolar is fine. But if you have a patient who has not been walking for 3 weeks, 4 weeks, 5 weeks, anything more than that, the cartilage of the acetabulum also has undergone necrosis. So those ones I think we should definitely go for a THR, not a bipolar.
That was I was saying.
Modular bipolar I said in acute fractures.
Yeah, acute only. So that's what he was mentioning. If you waited, somebody is not walked over on this leg for 3 weeks, it straight away goes for a THR. So is that clear for your answer?
And
I think we'll close this very wonderful session. Yeah. So thank you all the panel. If somebody doesn't mind, can we just have a picture of us, because some of us might be leaving.